So we have a goodwill message from the Honorable Minister of Health, in the person of Dr. Osage Hanire. So please, you may go ahead.
Thank you, Dr. Dubanjo, and I want to apologize to you and to all participants for this delay. We have had a slight mix-up and clashing of various activities for today. But this particular event is very important, so important that I felt I had to be able to find time to join and connect with you in this activity. And I am delighted to be part of this second National Scientific Conference organized by the National Academy of Science with the theme Applied and Translational Research in National Development, with the aim of bringing together stakeholders from government, academia, and industry to discuss how scientific research findings can be translated into innovations that will be of value to society and mankind. It also showcases research findings from our tertiary institutions and research agencies, which can offer opportunities for collaboration among stakeholders up to industry, productivity, marketing. I appreciate the invitation to be part of this important event, which essentially advocates for development of translational research to national development. This initiative of the Academy expands the dimension in connecting science and technology to industry and development, but also connecting to investment and financing. Research, therefore, plays a vital role in national development, and translating it is key to joining the global community of nations contributing to global knowledge and skills development, to manufacturing, production, job creation, industrialization, etc. It should be supported in all aspects for the significant impact it has on economic growth. I'm therefore pleased to note that the Academy is in sync with the transformational agenda of the present administration, and it is in this regard that government will gladly work with you, especially now that COVID-19 has been posing a serious threat to our citizens. Just this morning, I was at the 7 a.m. NTA Good Morning Show, where the focus was on research for vaccines and local therapeutics development. Nigeria has welcomed the fruits of researchers in these spheres, but we have a way to go with challenges around resource mobilization to support clinical trials and various validations required. The Ministry of Health is making efforts to arouse the interest of Nigeria's private sector and of financing groups such as the Sovereign Wealth Fund in engaging innovators. My participation today is a testimony of the federal government's interest and commitment to homegrown research and development, especially medical and pharmaceutical research, as dictated by prevailing needs and circumstances. I can confirm to you that the President of the Republic is a good friend of homegrown solutions and local content in all endeavors, and of the product of indigenous efforts, with the conviction that Nigeria eventually has to be able to pull itself up by its bootstraps. It is what also underpins this administration's eagerness to develop the energy sector and the transport infrastructure to ensure that electricity or lack of it and the difficulty of bulk transportation will no longer be hindrance to industrialization and economic growth. Insofar, you have an advocate at the highest level. There are times when, like at present, with the challenge of COVID-19, a global greenfield challenge is thrown at mankind that puts our own creative capacity shoulder to shoulder with the capacity of developed countries. As far as the capacity for problem solving is concerned, we find that we do not at all lag behind Europe and America, and I have come to admire the confidence that our scientists and researchers have developed in the course of responding to this challenge. But when it comes to translating solutions and discoveries to a higher production level, we unfortunately do suffer disadvantages, some being institutional, systemic, or structural, others due to too rudimentary infrastructure along the value chain. But I have been impressed by the achievements made by Nigeria's research entities. For example, the Nigeria Institute for Medical Research and the Africa Center for Excellence in Genomics, and many, many, many others who were quick to rise to the occasion and develop homegrown solutions to our needs for personal protective equipments, diagnostic reagents and kits, therapeutics, genomic sequencing, and even vaccines, one of which is actually awaiting clinical trial. I urge all stakeholders in research to work in synergy in the pursuit of inclusiveness in order to grow a country which we can all be proud of and begin to actually assert ourselves and our independence among the community of nations. I thank you all for your attention and wish you further fruitful deliberation. Over.
Thank you very much, Honorable Minister of Health speaking there. Thank you very much, sir, for creating the time. We can all imagine how busy you must be these days. So thank you very much. We're grateful. We take on the message seriously, and we hope also we can take on collaboration further between the Ministry of Health and the Nigerian Academy of Science in the very near future. Thank you, sir, once again. Grateful. So that was the Honorable Minister of Health with his goodwill message, and then we'll go right back to the presentations on that sub-theme 1. And I think the gentleman, Mr. Bamidele, dealing with fungi, apparently has not cleared the virus in the internet. So struggling with that for now. And so we'll go on to look and take the presentation by Loretta Antoimo, which is the third presentation there on effects of a multifaceted intervention on utilization of primary health care, again for maternal and child health in rural Nigeria. She's speaking from Benin City. So, Ms. Ntomo, over to you. Ms. Ntomo also having problems with the internet connectivity because she seems to have now disappeared.
I'll be using Dr. Ntomo's pre-recorded presentation, please. So I'm putting it up now.
Okay.
Yes, sir.
Maybe while you're doing that, I don't know if Dr. Etiaba is still there, so that while you're putting up the presentation, okay, not
yes, I'm here.
Okay, just quick question. So we have all kinds of policies, MSS, Shopee, and all of that. How involved were, is various stakeholders, particularly the communities, in the design of these programs? Did you do any work along those lines?
Okay, I was just typing in an answer to that question. I saw the question from Uche, all the panelists. So I was saying that community participation is a well-documented key factor in the policy process, be it from, however, that this study was looking at the supply side part of the policy. But there's a lot of literature to also show that when the communities are involved, I can share that because there's a different project which we carried out in the evaluation of one of these policies from the demand side and how their contribution and their contribution from the beginning, health facilities, ward development committee, how they contributed towards the mothers and children accessing care from their facilities. But this particular study is mainly looking at the supply side on the background of the current governance structure which we have, and which, if not changed constitutionally, is going to continue to affect policies, not just in the health sector but across other sectors, especially the social welfare sectors like education, agriculture, and all that.
Okay. Thank you very much. Well, the questions are in there also. I hope you're checking the Q&A section. But yes, there's a jam question from Professor Friday Okonofo, FAS, who you probably know, in the field of maternal and child health. Yes. And it says there are so many policies. So as someone researching into research for policy, what would you say if you were to mention two things? what is key to ensuring implementation and not just drafting of policies
Yeah, exactly.
in maternal and child?
For the next century, I don't think we need another maternal and child health policy. We have enough. What we need, yes, exactly. What we need to do is to go underneath and find out what is stopping our policies, the departure from policy intent to the policy outcome, that gap, to find out the things that are sitting in that gap and begin to close the gap. And I believe, obviously you can't study everything, but within the scope of my study, I'm looking at how governance structure, short of changing the constitution, how the governance structure, how we can work around it to begin to close that gap. We definitely do not need more policies. We need to do something with the policies that we have. And I appreciate Professor Konofa's question, because he should know.
Okay, thank you. So
thank you very much.
Thank you very much. So Blessing, do we have we might have time for questions, given again after this session, given the internet people have. So are you ready with the video presentation?
Yes, we are ready. Please confirm that you can actually see it.
Yes, we can. I believe we can
okay, so we are ready with that.
Our research is titled Effects of a Multifaceted Intervention on Utilization of Primary Health Care for Maternal and Child Health in Rural Nigeria. Over the past several years, there has been a global movement towards reducing high rates of maternal and under-5 mortality as essential prerequisites for socioeconomic development. It is for this reason that a reduction in under-5 and maternal mortality rates was included as major milestones to be attained in the MDGs, and now the Sustainable Development Goals. More recently, at the international conference organized by the UNFPA to commemorate 25 years after the ICPD, world leaders from several countries, including Nigeria, made substantive commitments to ensure the attainment of zero preventable maternal death globally by 2030. It is evident that if this new vision is to be reached globally, countries such as Nigeria with high rates of under-5 and maternal mortality would require specific attention. Nigeria's maternal mortality rate of 814 per 100,000 live births, as estimated by WHO, with an estimated 58,000 deaths per annum, and under-5 mortality of 117 per 1,000 live births, are currently among the world's highest. We conjecture that if an accelerated rate of decline in maternal and under-5 mortality is to be accomplished, Nigeria would need to focus on specific interventions on its most vulnerable citizens, such as those who live in rural areas. The Nigerian health authorities have put together primary health centers in many parts of the country, and indeed identified them as entry points to the country's health systems. Currently, we have about 36,000 primary healthcare centers in the country, located in different rural communities. But evidence from research, published research, shows that these primary healthcare centers are grossly underutilized. It is against this background that the Women's Health and Action Research Center, in collaboration with the University of Ottawa, Canada, began an intervention research in 2 rural local government areas in Edo State in 2015. The objective of the study is to determine the effectiveness of a set of multifaceted interventions designed to increase the access of rural women to skilled maternal and child care in primary health care facilities. The study was conducted in 2 rural local government areas, Esan Southeast and Esako East in Edo State. It was implemented by Women's Health and Action Research Center and University of Ottawa, Canada. The design was quasi-experiment using separate sample pretest post-test design. It was implemented in 3 phases. Phase 1 was the baseline, phase 2 was the design and implementation of intervention, and phase 3 was the post-intervention evaluation. At baseline, we used multi-methods to collect formative data. We conducted household survey with ever-married women aged 15 to 45 years. We also conducted exit interview with women who use PSCs in the 2 local government areas. And we spoke to elders in the 2 local government areas using community conversation. We conducted focus group discussion with married women, focus group discussion with married men, and we assessed 12 randomly selected PSCs in the 2 local government areas to see their service readiness, how much personnel they have, how their service readiness in terms of personnel, service readiness in terms of medical facilities and other facilities. The result of the baseline informed the design of the intervention. The intervention activities were designed to address the bottlenecks, the barriers identified at baseline. All the intervention activities except one were implemented through the ward development committees in 2 randomly selected wards, 1 per local government area, and the 4 PSCs located in the 2 wards. And all the intervention activities were implemented simultaneously. The primary outcome indicators include the number of women who use the project PSCs for antenatal care, for intrapartum care, the number of women who use the project PSCs for postnatal care, and the number who use the project PSCs for child immunization. These are the intervention activities. We implemented community health fund. This is a kind of local health insurance. Women enrolled into it with 2,000 naira, which they could pay over a period of 9 months. And when they enroll, a special card is issued to them. This community health fund is, the community members called it Egomo, meaning money to protect the child. When they enroll in Egomo, a special Egomo card is issued to them. In that card, their details are there. Their telephone number, address, telephone number of their partners, the telephone number of the WDC chairman in their ward, the telephone number for our rapid SMS intervention, which I will explain soon, and the key code for the rapid SMS. Women who enroll in this fund were entitled to free delivery care. They were also entitled to use our transport intervention and the rapid SMS intervention. Then there is the Memorandum of Understanding with Transport Business Owners. The WDC chairman in the 2 wards identified interested and committed transport business owners in their wards and enrolled them into this project. The transporters committed to transport women who are in distress to the project PSCs, and the fare was paid from the community health fund. Then we had the rapid SMS, which we call the Text for Life. This is a real-time communication between a woman who is experiencing any form of complication and the WDC chairman and the nurse project PSCs when she triggers a code. If she triggers a code, if she's in distress, she triggers a code. The WDC chairman gets a message with her details, and he quickly connects to one of the transporters in our MOU who goes to pick the woman to the PSC. At the same time, the nurse in the PSC is a woman in distress, so she begins to prepare to receive her. Then we had the drug revolving fund, which was implemented for all the PSC, all the 4 PSC project PSC. The technical support for this was received from the Ministry of Health. And then there is a community health talk. This is a kind of community sensitization and health talks led by the WDC chairman with input from the implementation research team. Then there is the advocacy. We had a very strong advocacy team who engaged stakeholders in the local government, state government, and the federal government. And then we had staff training and retraining. And then we provided basic equipment. All through the intervention period, we provided mama kits, refurbished some of the PSCs, bought pillows, mattresses, and a few other items. Then in phase 3, we assessed the effect of the interventions using the household survey with a separate sample of ever married women 2044.
Have you come
We used the
across?
same questionnaire that was used at
Have you
baseline.
done your morning ritual, your morning kitchen ritual?
The outcome
Eggs and
variables were
and
the use of
bread.
the PSC in the project wards for antenatal care, delivery care, postnatal checkup, and child immunization. The explanatory variable was the survey
I'm having
period, indicated at
a
baseline
conference
and
now.
end
No,
line. The baseline
not a
was
conference.
reference.
So maybe after
The difference in the
that,
outcomes between the two
you're going
periods
to be
was
presenting.
presented as a difference between the percentage at baseline and percentage at to determine the effect of the intervention on the utilization of PACs for maternal and child care, binary logistic regression was conducted, adjusting for clustering at community level. We also adjusted for individual and family level characteristics, such as the woman's age, her highest level of education, exposure to the media, among other factors. These are the results now. For indicator 1, number of women who use the project PACs for antenatal care. The percentage of women who used our project PACs for antenatal care at baseline was 52.6% for women who were currently pregnant. And it increased to 76.6% at endline, a difference of 24%. For most recent births 2 years before each of the surveys, the percentage at baseline was 40.8%, and at endline, 69.5%, a difference of 28.7%. Number of women who used the project PACs for delivery care. The percentage at baseline was 31.8%, which increased to 59% after the intervention, a difference of 27.2%. For postnatal care, for most recent births, the percentage at baseline was 41%. It increased to 69.5% after the intervention, a difference of 28.3%. For childhood immunization, the percentage at baseline was 59.7%, and it increased to 78.6%, a difference of 18.9%. And the use of other facilities in the project wards declined from 40% to 21%, and then we also adjusted for clustering at the community level. The odds of using the project PACs at endline compared to baseline for antenatal care increased 3.87 times. Delivery care increased 3.88 times. Postnatal care increased 3.66 times, and immunization increased 2.87 times. We believe that the positive result we have presented is a result of the approach we adopted in this study, which recognized and actually engaged the wisdom of community leaders and elders, the WDC, and the traditional rulers, as the primary agency that implemented our interventions. This approach actually enlisted their full participation and support, and enhance the effectiveness of the intervention. Many previous studies have shown that implementing multiple interventions simultaneously, the way we did, is a preferred option, is a preferred approach in rural communities, and they tend to yield better results. This project is funded by the International Development Research Center, IDRC of Canada, in partnership with Global Affairs Canada and Canadian Institute for Health Research, as part of implementation of IMCHA, which is Innovating for Maternal and Child Health in Africa. These are pictures from the project. Thank you so much for your attention.
Thank you very much. That was actually a video presentation by Mr. Tiaba, even though I think she's online now. My internet is stable enough she's disappeared. Well, I think she's there to be able to engage and perhaps answer a few questions. But yeah, from those who might, actually from Loretta. I do apologize for that. So Loretta, is your internet okay now?
Hello, can you hear me?
Yes, we can.
Not so steady, but
Okay, great. I hope you'll be able to take or maybe answer one or two questions
Yes,
If
sir.
okay, my own key question is what exactly from the study, what exactly would you think is key at the moment that your study, I mean, what policy really do you think your study is particularly aiming at influencing?
I, I, I I think our study going back.
Oh, okay. Yeah, muted if you can hear me. Oh dear.
Hello.
Yes, now we can hear you.
Okay. Now I think that our results point to engaging the World Development Committee. We
Right.
have them we have them in almost in all the wards in this country. We can engage them more effectively when it comes to health intervention. It helps because the community will own the project. The project is being implemented by
Right.
development
That
partners of the Nigerian government. I think is a good strategy for us to engage them more effectively so that the outcome of our interventions can be sustained. As I speak to you, they are still going on with the community health fund. They are still going on with the rapid SMS because they owned the process. They owned the process.
great,
They owned the project.
great.
And even when we have gone,
And it's
we
good.
can still continue. Thank
It's good that you emphasize the World Development Committee. And I have a question from Dr. Bade here in the Q&A section for you, saying, how do you engage the WDC chairman and leadership? Are they remunerated officials of a local government? So are they officials? Did you also have to remunerate? What exactly, when you say we engage them and we involve them and all that, what exactly did that entail?
Okay, they were not remunerated. We didn't have money for them. We only, at baseline, when we got into the communities, we met with the traditional rulers, and then we met the committee. The committee in those local government areas, they are already overseeing the activities of the PSCs in those places. So all we needed was give them, had a talk with them, present our project, and they were willing to run with it. They were part of the planning. They were part of the designing of the intervention. However, whenever they had to attend a meeting, we pay for their transportation. Like whenever they had to come to Benin, we took care of all their logistics. But there was no stipend for them. These people were willing. They were already a seated committee in these local government areas, and they ran with it. They ran with it. They kept all the records. We didn't have to pay them because we know paying them is not sustainable.
So that's good.
It's like a better thing, engaging them. Not that you plan it in Benin and then you come to them with it. We engage them from the beginning. They were part of the decisions. They were part of every single thing we had.
Great. Thank you, Loretta. So in line with Professor Uche comment here, talking about the study being good and deserving scaling up, do you think that this is reproducible, across the country? Do you think that this can be done everywhere? Or you think that the people you dealt with were just special? They were not really Nigerians in that sense?
Honestly, I think it's reproducible because Nigerians are actually used to self-help, and WDC is in every community in this country, in every ward in this country. And the process we took for this project, their processes are very clear, very very reproducible. You can reproduce them. And if you followed one of our interventions is the rapid SMS. The rapid SMS can be reproduced. The community health fund can be reproduced. I can tell you most Nigerians are used to self-help projects. In the village where I come from, the electricity was a community health community project. People contributed and they put up electricity there. So even in all these other communities, people are willing. They are willing for a change. They want something new. They want some progress. So if we engage them in the decision process, they will run with it. They will own it. As I speak to you, the drug revolving fund is run by them. They own the community account, bank account, where they put in the money and they know what to do. So they are the ones running it. and they are accountable to the traditional ruler. So I think it will work in every part of this country. I am very optimistic that it will work. If it worked in these two local government areas and still working after we have completed the project, it can work anywhere because Nigerians are willing, Nigerians are used to self-help projects, and they want to drive this thing. Just give them a small step. And I can tell you, we didn't have to spend so much. For instance, refurbishing the primary health care center didn't have to take much. Ensuring that there is a nurse midwife in all our projects, I didn't have to take much. We only did the usual advocacy and we got them. Thank you.
Thank you very much. And I hear that Professor Konofa is typing in there that indeed plans to scale up to 10 states with support from UNFPA. So that is great. It's great to hear from you. We unfortunately not still have Mr. Bamidele for the second oral presentation. His internet is not cooperative at all. But I think that might also work for our good because we have the poster session that we missed out earlier on, and we might be able to just get back to that now and take that on before we go on a break, a lunch break, which you will have your virtual lunch, and then we'll reconvene at 2 p.m., from 2 to 4, 2 to 3:45, let's say 2 to 4 p.m. We'll have the last session, and then tomorrow we'll start off again. But before that break, we should have the posters now. So, Blessing, I'll set.
Okay, just a minute, please. Let me set that up. Okay, I have that up now. Please confirm that you can see it.
You have started screen sharing, but we can't see anything on the screen yet.
Can we see it now?
Yes, we can.
Okay, all of these posters are also available to be viewed on the NAS YouTube channel. So please, you can all go there. The link will be made available in the chat box. So participants can view all of the posters.
Not very clear. I don't know what you see, or maybe it's whether you're on full screen mode or not.
Yes, it's the resolution. Yes, so that's why we also made it available on the YouTube channel so everyone can see it there. It's more elaborate there. This is just a preview.
I think it might not therefore be very good to have this because we can't read anything. So do we have the adverts on instead?
Yes, okay.
Just take on 2 adverts we have before our break. So posters will be available on the website, the NAS website. I think that will be typed up in the group. So www.nas.org.ng, you should be able to get posters, even the adverts. And people have been asking questions. Yes, the presentation slides will be shared. Yes, the recording also should be shared soon after the conference. Okay, Blessing, seems you are struggling with that. So Blessing, please confirm that's all.
I have one more, please, before we go on our break. I'm putting that up.
Okay.
Imagine the joy that fills your heart when you have just given birth. Guys, we got you. Imagine the joy that fills your heart when you have just given birth.
Listen, it's frozen, so I think you should just alt it.
Whatever your size, we got you.
Okay.
Okay, so let me thank everybody for this session on research for policy and practice. Thank you all very much for your participation. We'll take a lunch break so that you can get something to eat. If you can just type on the screen to your left-hand side, and you can get a virtual delivery of rice, pounded yam, or eba, if you wish. But we will reconvene at 2 p.m. For the session on translational research in medicine, which will be chaired by Professor Sunday Atawodi, the Academic Secretary for Biological Sciences of the Academy. And we have a lead presentation at that time, which I think you shouldn't miss, coming from the Director General of the Nigerian Institute for Medical Research, Professor Babatunde Salako. He will be giving the lead presentation there. We have the interesting presentations of original research. So 2 p.m., please come back online. Platform will be open again, and you'll be able to, you can all come on board and we can start on time. And at the latest, we should be done 45 hours. So let's do that. Thank you all very, very much for your participation, and see